Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, my name's Laura Waters. I'm a consultant physician in HIV and sexual health from the Central and Northwest London Trust in London in the UK. And welcome to episode 1 of 2 clinical clips reporting from HIV Glasgow 2022. Now, the first study I'm going to talk about is an analysis from the STAT and Gemini studies looking at the efficacy of dolutegravir lamivudine dual therapy in people with higher baseline viral loads. Now, Gemini, which was the landmark study comparing first-line dolutegravir lamivudine with tenofovir disoproxil, emtricitabine, and dolutegravir, so a 2 versus 3 drug regimen first line, excluded people with viral loads above 500,000 copies per mil at screening. However, because of the gap between screening and baseline visits, a small proportion of people did have viral loads above 500,000 by the baseline visit. There's also the STAT study, which was a single-arm study exploring dolutegravir lamivudine in a test and treat same-day ART strategy. Now, this analysis, in order to address that concern, which is expressed in the guidelines, because the DHHS, the EACS, and indeed at home our British HIV Association guidelines don't recommend dolutegravir lamivudine first line in people with viral loads above 500,000 copies. So this analysis looked at the small proportion of people in Gemini, about 2%, and the higher proportion in STAT, 15%, who did have a baseline viral load above 500,000. And essentially what they showed is high rates of virologic efficacy. In the Gemini studies, the rates of viral suppression were at least as good in the 2-drug regimen arm as it was for 3 in people with a high baseline viral load. That was 91% versus 79% for 2 and 3 drugs respectively. Now, that difference might sound quite large, but the numbers were small. But it's reassuring there was certainly no underperformance of the 2-drug option. And in STAT, people performed well, or viral loads were suppressed well, regardless of the baseline viral load. So I think this data adds to the fact that dolutegravir lamivudine probably performs as well above 500,000 copies per mil as other regimens. The screening quirk of Gemini means the guidelines have limited its use, but we must consider that even other 3-drug regimens such as bictegravir, tenofovir, alafenamide, and emtricitabine only had a very small proportion of people with viral loads above that 500,000 cutoff, so the data is limited for all regimens. PIBIC was a study looking at switching people from protease inhibitor-based therapy to bictegravir, tenofovir, alafenamide, emtricitabine with baseline NRTI resistance. Now, bictegravir-based regimens haven't been studied in people experiencing virologic failure, but there's accumulating data looking at this regimen in suppressed switch in people with resistance. So PIBIC took people with at least one NRTI resistance mutation. For some, that was the 184V or I, with or without other nucleoside reverse transcriptase mutations. For others, it was NRTI mutations, including thymidine analog mutations, with or without the 184. And essentially, the small study shows that the 33 people who switched compared to the 39 people who stayed on a boosted PI all saw maintained viral suppression out to week 24. There was one person who didn't maintain viral suppression in the PI arm at month 6. In terms of other impacts, there were higher numbers of drug-related adverse events. So close to 40% of people experienced drug-related adverse events who switched to bictegravir, TAF, and FTC. And there were more discontinuations, perhaps not uncommon though in studies where people are stable on a regimen and switch to a new class. Headache, weight gain, abnormal dreams, and insomnia were all more common on dolutegravir, but there was an improvement in lipids. So lipid parameters improved with switch, other than HDL, which went down slightly. There were small increases in weight, BMI, and HbA1c, but no difference in waist circumference between the 2 groups. So these early results add to the data that people with suppressed switch and limited NRTI resistance can safely switch from a boosted PI to bictegravir-based triple therapy. HPTN 083 is a landmark prevention study comparing injectable cabotegravir given every 2 months with daily oral tenofovir disoproxil and emtricitabine for people at high risk of HIV who are men who have sex with men or transgender women. Now, 083 has already shown us that injectable CAB is superior to daily oral PrEP when it comes to HIV prevention, consistently with a relative risk reduction compared to oral PrEP of about 66%. Now, this analysis presented at HIV Glasgow looked at an additional infections that occurred after the unblinding of the study. And in this unblinded phase, they looked in great detail at the drug levels and the viral load results and the resistance results in people who acquired HIV despite being on PrEP. Now, what it shows is there is a small number of people who acquire HIV despite having on-time CAB injections, and there's high levels of integrase. In fact, all people who acquired HIV despite on-time PrEP developed integrase resistance. There's also a high chance of resistance in people who initiated or reinitiated CAB PrEP because of unrecognized HIV. And there was one person who saw very rapid reduction in CAB levels that needs further exploration. What does this mean? Well, it means IM CAB works well and fewer people acquire HIV on IM CAB PrEP. But I think we really need to understand these HIV acquisitions and to look for the correlates of protection so we can best select people for this highly effective prevention strategy. We saw the results from a study undertaken in China in people with newly diagnosed HIV looking at options for rapid ART. People who were eligible were randomized to bictegravir, tenofovir alafenamide emtricitabine, or efavirenz tenofovir disoproxil emtricitabine. And we saw week 24 viral suppression results. There were more withdrawals from the efavirenz arm. There was one death due to suicide. And overall, the bictegravir arm saw superior rates of viral suppression. Almost 94% of participants suppressed at week 24, compared to just under 75% in the efavirenz arm. There was no difference in CD4 results. There were more drug-related adverse events in the efavirenz arm, and there were more adverse event-driven discontinuations. Now, these results are early, but this is clearly suggesting that the bictegravir-based option was superior to efavirenz in the context of rapid ART in China. So thank you for joining us for clip 1 of 2 of these HIV Drug Therapy Glasgow clips. Please visit the landing page to view these slides and clips from other conferences.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.